So I am going to welcome everyone. So excited that you're all here with us today. This is our International Alliance of the Academies of Childhood Disability, our COVID task force. Specifically, we have come together with over now 30 different countries across the world to be together on World Cerebral Palsy Day. And I had just mentioned, I am sitting in the central time zone of the United States, so it's Chicago time, and we are at 2 p.m. in the afternoon. So we have been following the sun across the globe. We started in Fiji and now we're moving. So if you can see the globe here, we're actually moving along and we're moving towards our last 5 to 6 hours of this incredible marathon of listening and sharing sessions. And so we've been doing this 24-hour virtual session. So we are apart, but we are very together in all of this. And we'll learn even more about that as we're together here today on this call. So I wanted to first off, start off by, if you're willing to do so, just alert you to some of the buttons that you may be familiar with. When you are with us here, if you could be on mute, but if we could actually ask you to turn on your video, it's exciting to be able to see everybody from around the world. So no matter where you are or what you're doing, I'm sitting here in my living room with my bathroom door closed so that no one's looking directly in my shower. But so if you would be so willing, it's great to see everybody and be able to celebrate being together. So you'll be muted until the time that we open up for listening and discussion. If you need any assistance with that, there is a button at the bottom that you can hit the microphone to unmute or mute. There is an individual, Jenny Carroll, who's one of my colleagues, who's actually running behind the scenes on this to help us as well, so she can mute you or unmute you and help you if you're struggling with that. Again, if you could turn your video on, that would be outstanding in terms of what we're doing. If while I'm introducing this session, if you don't mind in the chat, so if everyone can locate the chat, if you don't mind writing the country that you are coming from, we'd love to know where you're coming from. So if you could enter in the chat, just the country that you're representing, we'd love to see where you are all from. So thank you for participating that way. We will be saving this video and the chat. So just to be able to be forthright about that, just so you know that. And I will be the moderator of this session. My name is Bernadette Gillick. Again, I am from the United States and representing the United States in the International Alliance of the Academies of Childhood Disability. So a couple of ground rules as well. We're going to mute when the speakers are talking so that we can have a quiet background for them. If you would like to ask a question, you can raise your hand, and that is actually an opportunity at the bottom. You can see that there are different buttons that you can push. So in terms of reactions, you can raise your hand. And you can also clap if you want to, using those buttons as well. I want to make sure that I explain that this is a very safe place, that we're excited that you're all here. We want to hear what you have to say, respectfully, of course, with appropriate comments, but we really are looking forward to listening to you and the discussion. So please share with me alone, privately in the chat if you'd like to, if there's something that you would like to elucidate or clear up, and I'm happy to help try to facilitate that discussion. So what's going to happen with this session today is 1 hour total. We are going to have a brief presentation from our two presenters. They will introduce here themselves, and then we will listen and open it up to different questions from you. So we're going to field those different questions as well. And I'll facilitate that moderation from the chat. And so for the two speakers, I actually would ask today that you would introduce yourself and use your brief bios to help us to understand who you are and your background. So we're excited that you're here. I'm going to stop sharing my slide here, and I'm going to allow the speakers to share theirs. So Ellen Suter, if you would share yours, that would be fantastic. So I welcome you, Ellen Suter and Linda Francis, and if you don't mind both, just before you begin, explaining who you are and some of your background so we can appreciate what your background is. Thank you for being here and sharing with us.
Great, thank you, Bernadette. Can everyone see my slides okay? All right, so my name is Ellen Suter. I am a physical therapist and a current rehabilitation science PhD student at the University of Minnesota. My research interests are in working with infants and children with cerebral palsy and asking questions related to rehabilitation and neuroplasticity. But for the past several months, I've been really focused on this survey relating to the impact of COVID-19 on the children and families with whom we work. Linda, I'll let you introduce yourself before we go forward with the slides.
Now you can hear me.
Yes.
Yes. Hi, I'm Linda Francis, and I am at the University of Rochester in Rochester, New York, in the Graduate School of Education and Human Development. I have been an adjunct faculty in human development. Right now, I am writing my dissertation, and my area of research is family caregiving, specifically caregiving in ethnic populations in the United States. And my methods of research are qualitative analysis and narrative analysis.
All right, thanks, Linda. So,
Thank you. So I will hand it over to both of you. Thank you again for being here with us today to learn about your exciting research that has just happened hot off the presses. Thank you again.
all right, so we're excited to share with you today the results of our survey, which we've conducted during the COVID-19 pandemic to assess the impact of the pandemic on children with disabilities and their caregivers, and specifically related to access to rehabilitation therapies. So when we were planning this survey in the spring, all of us were impacted by the pandemic in many aspects of our daily lives. The pandemic has disrupted healthcare, employment, education, and so many other aspects of our daily routines. Specific to healthcare, in the United States, there's been government mandates, both federally and state, that have affected some healthcare visits deemed non-essential, and has caused some healthcare appointments to be transitioned to telehealth or postponed to a later time. But with our survey, we wanted to know specifically how the pandemic was impacting access to rehabilitation therapies for children with cerebral palsy. Questions of, were therapies being affected, and if so, how? And we also wanted to look at the implications for child physical and mental well-being and caregiver burden. So the aims of our survey were to understand the impact of COVID-19 on access to rehabilitation therapies, to identify the impact of these disruptions to therapies on child and caregiver physical and mental health, and then to begin to assess the needs and preferences as reported by caregivers for delivery of alternate or virtual interventions. So our survey was performed completely online. We used the online platform RedCap, and we emailed the survey to parents and caregivers of children aged birth through 18 with childhood onset disabilities, which were primarily cerebral palsy. The surveys were anonymous, and they were completed between May 15th and July 13th of this year. And for some context, during this time range in the United States, regulations were changing. So at the beginning of this time range, in May, the end of May and early June, many states were under a strict stay-at-home order. So families were instructed basically to not leave their homes except for essential activities. Towards the end of this time range, some states were relaxing those regulations and beginning to open up certain parts of different activities for families in areas such as healthcare, employment, businesses. And so these state regulations also would have impacted potentially what in-person healthcare was able to be accessed. We had 3 recruitment sources for our database, and I'll show you on the map here where in the United States we were primarily recruiting from. So we used our lab database and also a hospital, Gillette Children's Specialty Healthcare, both located in Minnesota, where the blue star is. We also recruited from the Cerebral Palsy Research Registry, which is based in Illinois, where the other blue star is. So we expect that most of our participants are likely from this region in the Midwest United States, shown in the red circle here. However, we know that some of our databases do have a nationwide reach, so it's quite likely that participants from other states are also included in our data. So here are the types of questions that we included in our survey. And again, all these questions are answered via caregiver report. So we asked about the demographics of the child. what therapies they were receiving before the pandemic in types and hours per week, and then also what therapies they were receiving at the time that they were surveyed, so during the pandemic, their satisfaction with the therapies they were receiving during the pandemic, and then physical and mental health experienced by the child, and caregiver burden and mental health. We also asked 3 open-ended questions in our survey, and these were: what are the main challenges you have faced with respect to the access and quality of the treatments and services provided to your child? What solutions, ideas, or support have you found helpful or beneficial? And lastly, whether there is anything else they would like to share with us regarding their child's access to rehabilitation, healthcare, and/or support services during this time. So we had 102 respondents to our survey, and the demographic data of their children is reported here. So the average age of the child was about 10 years old, but we had children ranging from 15 months to 18 years. The majority of caregivers had male children, and we had families who were spread out in different types of locations. So we asked them to self-report how they would describe their home, the location of their home. And so the majority were in suburban areas, but we did have representation in urban and rural areas as well. And then, as I mentioned, the time at which they answered the survey often influenced whether their state had a stay-at-home mandate at the time of their survey completion. But we didn't actually capture what state they were in. So we know that among the United States, there were some differences in what the regulations were at different states at different times. But so by asking them whether they had a stay-at-home order, it helped us get an idea of what those restrictions may have been. All right, so this graph on the left looks at the types of therapies that children were receiving before COVID compared to the types of therapies they were receiving at the time surveyed. So for pretty much every type of therapy that we asked about, fewer children were receiving that therapy during the pandemic compared to those that were receiving it prior. I think perhaps most impactful is this number here. Prior to the pandemic, 92% of participants reported that their children were receiving 1 or more therapies per week. But during the pandemic, only 54% of the children were receiving any therapies per week. And again, this is specific to the time point at which they were surveyed. Of those that were receiving therapies, the box on the right shows the method of therapy delivery. So video call was the most common, with 76% of participants who were receiving any therapies during the pandemic reporting receiving them via video call. But at the therapy centers, phone, email, or home visits were also reported. And some participants reported that they received therapies via multiple different methods, which is why the percentages don't add up to 100. Also to note that we didn't find that there was a difference in the change in number of therapies that children were receiving dependent on a stay-at-home order. So basically, participants were equally likely to report receiving a decrease in therapies, regardless of whether their state had a stay-at-home order at the time that they responded. So I think this suggests that state mandates weren't the only thing that was limiting therapy access for these children. Oops, sorry. This table displays satisfaction with therapies, and this was for a subset of participants that were receiving at least one therapy during the pandemic. So 49% of caregivers did report that they were somewhat or very satisfied with the therapies that their children were receiving, and this could have been via any method. But responses were overall mixed, and I think later when we talk about some of the qualitative data, you'll see why some participants found both advantages and disadvantages to the modalities of therapies that were available. All right, so this slide shows some of the results that we found about child physical and mental health. So for these questions, caregivers were asked to compare their child currently during the pandemic to before the onset of COVID-19. And responses were either yes or no type questions, or they were rating them on a 5-point scale. So 43% reported a decline in their child's mobility and movement related skills. 61% reported that their child's physical activity was somewhat or a lot less than usual. 25% reported that their child had outgrown or unusable assistive equipment that they weren't able to get replaced or adjusted. 61% reported that their child's stress and anxiety was somewhat or a lot higher than usual. And 41% reported that their child's behavioral issues were somewhat or a lot higher than usual. We also compared these impacts between participants that received fewer therapies than usual during the pandemic and those that continued to receive the same number of therapies during the pandemic as prior, regardless of the method of delivery. And so we found significant differences for these two impacts, where participants who continued to receive the same number of therapies during the pandemic as prior, even if the modality had changed, were less likely to report a decline in their child's mobility, and also tended to report a less negative impact to their child's stress. Similarly, we also looked at caregiver mental health and burden. And in general, caregivers reported that their burden and stress was much higher during the pandemic compared to prior, with 85% reporting that caregiver burden was somewhat or a lot higher than usual, and 84% reporting that caregiver stress and anxiety was somewhat or a lot higher than usual. Here too, caregivers of children who continued to receive the same number of therapies during the pandemic as prior reported less negative impact to their stress and burden. And caregivers whose children were receiving fewer therapies tended to report higher burden and stress. All right, I'll turn it over to Linda now to talk about some of our qualitative findings.
Thank you, Ellen. As Ellen has mentioned earlier, the participants responded to 3 open-ended questions related to their experience assessing services during the pandemic. Qualitative methods, in particular thematic analysis processes, were utilized to analyze these questions. From the processes, we managed to identify 5 things, and we used participants' quotes to show evidence and to support our selection of these main themes. The first theme, unable to access needed care. As expert caregivers for their children, participants recognize the impact on access to needed care, such as closed treatment centers, school closures, and inadequate internet access and other technological issues. It's important to note that we used the participants' exact words. We made no effort to edit their responses. The second thing, unable to access needed care. The second thing, benefits and limitations of telehealth. Participants who were usually parents realized that telehealth delivery of needed services and therapies was not ideal. For participants living in rural communities, especially those who drove long distances to obtain needed services for their children, they responded very positively about the telehealth services that they were receiving. Next slide, please, Ellen. Thank you. The third theme, the child's physical and mental well-being. Caregivers expressed concern that the ongoing reduced access to care would negatively impact their children's health and well-being. One caregiver noticed significant change in their child's physical condition. This caregiver stated that we have gone backwards considerably. Another caregiving parent noticed significant change in their son's mental health and felt that this put more stress on the entire family. Next slide, please. Thank you. Our fourth theme really looked at caregiving demands that contributed to caregiver burden. Caregivers' well-being is generally influenced by the needs of the children with whom they provide care. Often physical and emotional demands of satisfying the child's needs, at times providing around-the-clock care, also include balancing work and family responsibilities and meeting financial obligations. If you note, one single mother seemed to be especially impacted by her caregiving responsibilities because she felt she was the whole support, the only support for her child. An additional stressor might be a caregiver's feeling that they could have done more. One parent said, "I know it's a lot of work, but what is the alternative? Look back years and wonder, could we have done more for our children?" And the final theme 5. While the parents fully acknowledge that caregiving for these particular group of children can be very stressful and can lead to perceived burden. However, the negative impact of these stresses is often mitigated by caregivers acknowledging positive aspects of their caregiving experiences. One caregiver freely acknowledged that family support and access to creative therapists, access to helping therapists, and also additional professionals may have contributed to her positive aspects of caregiving. Caregiving therapies that were especially child-centered seem to be definitely a positive aspect of caregiving. Also, when caregivers felt equipped through either their particular training, their experiences, and what they perceived as distinct advantages, they were more likely to express positive aspects of their caregiving experiences. That's it. Thank you.
All right, thanks, Linda. So just to summarize, this survey clearly found that access to therapies was disrupted during the pandemic in our sample. And in the qualitative data, we can also see that access to therapies was a major concern of the caregivers. Satisfaction with therapy delivery was mixed, with the respondents having both advantages and disadvantages of telehealth and other therapy options. And the disruption in access may be related to some of the child physical and mental health impacts that were reported. Caregivers did report increased burden, but as we noted, there were also many positive aspects of caregiving for children during the pandemic. Our survey is limited by the fact that it was a non-random sample and the responses were only obtained at one time point during the pandemic. However, our findings are really similar to some other surveys that have recently come out during the pandemic, specific to children with disabilities worldwide, such as the European Academy of Childhood Disability, a survey completed in Italy specific with children with perinatal stroke, and one in Australia. So I think overall the responses to our survey suggest that the resources that have been available to families during the pandemic, such as access to telehealth, different government or other support systems, have been beneficial in many instances, but also haven't been sufficient to mitigate all the detrimental impacts of COVID-19 on children with disabilities and their caregivers. I think we also see that caregivers really value the services that therapists provide, and they value when they have had access to therapies during the pandemic, but also they've valued what their children have been able to have in the past. But I think it also presents an opportunity for rehabilitation providers to use this input and feedback of children and caregivers and seek more input and feedback from children and caregivers to be responsive to the experiences of families during this pandemic, but also to be resilient to future challenges, and particularly through improvements and increased access to remote care and support. So with that, I'd like to thank all the lab members and the other and our collaborators who have contributed to this work. I did include our lab email address for more information about, or our lab website address for more information about current studies, and my email address, so you can feel free to contact me with any questions. But with that, I'd like to turn it back over to Bernadette. We welcome any of your questions, comments, or experiences that you'd like to share right now.
Thank you very much, Ellen. I appreciate it. So thank you also for the summary at the end, and for both of you putting in the time and effort to present to us today from a perspective from the United States, and a nice sample. On this call today, we have people from India, Wales, the Netherlands, Spain, Israel, the United States. And so in this, obviously, Ellen just mentioned that this compares to some other studies that have been done in Italy, also at the European Academy, throughout the countries in Europe, and also in Australia. So something that I think would be an interesting question for everyone, if anyone has thoughts on this, but also in the chat, is what was the extent of the stay-at-home orders in other countries? We have a huge swath across the world right now of individuals on this call. Can anyone from any of the other countries explain to us what were the stay-at-home orders and the access to rehabilitation in their country? And feel free to either chat or raise your hand and we can let you in. Jenny Carroll, please.
I was going to say, it might be worth to start with stopping sharing, and then we can all
Sure.
see.
Ellen, if you don't mind stopping, then we can see each other. Great. Thank you, Ellen.
It varied where we were. It's interesting as well, because we're Wales, which is on the side of the UK, and we've got different rules to the rest of the United Kingdom. But when we first started doing lockdown, it meant you weren't supposed to go out except for essential shopping and for an hour a day of exercise. But now it's a lot freer. You can go out, but we're all in different local authorities. We're restricted to our area. So I'm restricted to my local authority area, but I can go out in that sort of as much as I like, but I'm supposed to keep distance, wear masks indoors for mixing with people. Yeah, 2 meters. There's restrictions on who you can't go in anyone else's house. And if you go, you can still go to pubs and restaurants, but you have to go with your family group and then be a social bubble within that. There's few rules that seem slightly contradictory, so it's not always really clear about what's allowed and what isn't.
Thank you very much. Anyone else from another country? Could you give another example? So that we have Wales and the United States. Okay. I'll ask a question a different way. There was one family, as noted when Linda was speaking as well, there was a concern for the decline in mobility. And we have healthcare professionals on this call right now. Is that a concern that you all share in your different domains of healthcare? Whether you're training to be a healthcare professional, whether you are a healthcare professional, or have thought about that, or that your country has thought about that in terms of decline in mobility. Dawn, thank you. Yes. Dawn, I think you're still muted. It's a Zoom catchphrase.
Sorry.
Not at all.
First of all, thank you so much for the presentations, both of you. It was really good to see that. And the parent quotes are quite telling, aren't they? Just, but it's really good to have them. I was just thinking, about the mobility. One of the things that the survey came back with was that 61% reported the either somewhat less or a lot less of physical activity. And I've wondered about if, it's quite hard to tease out all the different factors, isn't it? Because lockdown happened, everybody was staying inside anyway. and it would depend on your environment very much. But you know, how much of it was due to the fact that actually nobody was going out and they had to stay, you know, in the house, especially if they didn't have a garden, if they lived in a flat or an apartment, then mobility is going to go down, because generally you're just not moving around as much, are you?
Right.
So just wondering about, you know, the factors that are, all the factors that are involved with that. Is it not just about therapy, but just physically not being able to go out?
Great point. Linda and Ellen, do you have any comment to that?
Yeah, I was going to make a comment. I think you're absolutely right. I mean, it is really hard to tease out all the different aspects that might contribute to limited physical activity. I think even not having in-person schools and access to some adaptive physical education would be a concern. And many of the caregivers, particularly when their children maybe had more physical limitations, just stated that it was really physically difficult for them to take full-time care of their children. And so I would imagine that if their children are requiring considerable physical support, that parents may not be equipped to provide their children with opportunities for physical activity as much without the support of outside caregivers. But I think certainly not leaving their homes, not having access to recess and you know, organized sports or adaptive sports, whatever the children were participating in, I think all of those would definitely contribute.
Linda, any comment to complement that? You are muted as well. That's good, Dawn. You're not alone across the world there, right?
I'm unmuted, finally.
There you are.
Yeah, we saw in the qualitative data that many of the parents were very much concerned about the lack of physical activity, not just the results of it on the child's particular physical disability, but on the child's well-being. Children needed to be with other kids. And I think not for the play and the emotional support, and this lack of physical activity, lack of engagement with other children, I think was as important to many of the parents as not having actual physical activity. Because I think we as parents realize that quite often physical activity and mental well-being go hand in hand. And I think we did have parents who expressed that.
Very good points.
Thank you. Yeah, I would say it's not just the children, it's the adults as well that need that contact with other adults. I mean, it's great that we have the Zoom, but it's not like the real thing, is it?
No, it's not, Dawn. That's a very humanistic perspective, and it's very true. Christy, I think you were going to have a comment as well. Were you not? I don't mean to cut you off.
Oh, I was just going to say that. So I work in the school setting. So we went for a long period of time without seeing kids. And where I live right now, the children have the first 6 weeks of school. It was very limited on who was allowed to come back in the special education department. And then now parents have a choice whether or not to have their kids go face-to-face or stay virtual. My parents, the majority of them are remaining virtual.
Is that right?
And so I know they're not able to address some of the goals that the kids have necessarily. Say they have a power wheelchair and they're learning how to drive in crowded hallways in school. I have some that haven't gotten in their wheelchairs in 6 months to practice those things. It's really a difficult thing for them. So I think the impact of what their lack of being at school and the lack of intervention, I don't know exactly how that's all going to play out. I think time is going to tell here pretty soon for us, but
yeah. And that's a perspective of the school-based as well, what's happening for individuals. And as Ellen and Linda were mentioning, I think it's highlighting how important are these services to the family, to the caregivers, as well as the children? What meaning do these services have? You know, it's all of the challenges, as you were saying too, Dawn, environmentally, and also access to care and the desire as well. So there's a comment from Linda Kroc, who said, I have seen a decline in mobility in adults and children with cerebral palsy and spina bifida. And speaking with the adults, they indicated that they are walking much less than usual since they've been largely confined to their homes. And we are talking about trying to increase activity gradually as they are able. So that conversation from adults as well, in terms of what they're doing, adults with potentially childhood onset disability, that they're working with those confines too, along the lines of what you were just saying, Dawn, as well, on piggybacking with that. I think that the beauty of a study like the one that you, Alan, and Linda did is that this might be something that someone would say, well, there was a stay-at-home mandate, people stayed home, so of course it had an impact. It might be something considered a proof of principle, which is a good thing, because we want to be able to say there was a change, and you can't talk about change unless you measure it. And so I think that this is actually highlighting in one way, and there's going to be multiple ways to look at this, but highlighting in one way what is actually happening for a lot of people. From a caregiver perspective and also from a child perspective. Anyone else have a comment or a question for the speakers? Okay.
I'd like to make a comment.
Please.
I'd like to make one final comment, because so much of my research with caregivers of patients with cognitive impairment is very similar. But one thing we always look for in the caregiver stories, positive aspects. How are you coping? Because if caregivers have the strategies to cope with the adult or the child's disabilities in a very positive and productive way, we see much less perceptions of burden. Mm-hmm. And the caregiver and the person with whom they provide care seem to do much better if indeed the caregivers can find something positive about their experience. And I think we heard some of that in the stories and the comments from some of our parents and our caregivers.
Okay. It is an interesting study from you both, because we're evaluating the impact on the child, but we're really evaluating it through the eyes of the caregiver and through their experience in this way as well. So very, very unique with that. Very good point. Thank you for that, Linda. Okay, Jenny, you have your hand up.
Just another question. I wondered if you collected the GMFCS levels. I didn't spot that, or I may have missed it. Just wondering whether there was a difference in what their GMFCS levels were as to the severity of the impact.
Very good question.
Yeah, I can take that. We did not collect the GMFCS levels for a couple of reasons. I think we didn't have, not every child on our database necessarily has a formal CP diagnosis. Some have similar types of motor impairment, but not specifically CP. And I think looking back, I agree that could have been a really interesting thing to ask. I think at the time we were focused a little bit less on specifically what level of disability or impairment the child had, and more just on the general impact. But I agree, now looking back, that would have been really interesting to look at.
You can't ask everything, can you? You know, when you go back, you always want more and more things, and then you end up with
of course
that no one fills in. So it's always a compromise.
Right, and it was a pretty, we wanted to turn it around pretty quickly too, given the unique, the rapidly changing situation. So there definitely would be some things we wish we could have asked.
Do you think you'll repeat it to see whether that's changed as you go into wave 2 or wave 3 or whatever happens? Do you think you'll ask the same questions again to the same people?
We've actually thought about it. We only have a subset that we could actually where we could actually kind of track who completed the survey, because just to maintain their anonymous, the anonymous nature of the survey, we can't necessarily follow up with all of them. So that's a great point and something that I think we've considered. I'm not sure if we're going to explore it at this time or not, but I think that would be really interesting.
On the back of what Jenny was asking, interestingly enough, Jenny, one of the physicians from Mayo, and I say this as a background, full disclosure, I'm obviously on this study in the background, but I did not do the work of it. It's Ellen and Linda who did. But one of the physicians in the beginning said that he hypothesized that GMFCS levels 1 and 2 would actually be disrupted more than levels 4 and 5. And I thought that was a very interesting hypothesis in terms of the impact that they may have both cognitively and motorically. That cognitively, they may actually be impacted more, meaning that they are potentially higher functioning. And because they're higher functioning, it might impact them more. And so we weren't able to put it all in there, as Ellen said, but the question is so good, Jenny, in so many ways, and that would be a very interesting subset to evaluate for certain. There's a question from Leaky here. What is your vision on helping to prevent contractures in children with spastic cerebral palsy during a lockdown? Ellen, I think I would give that to you in terms of what is your vision for children with spasticity, with spastic cerebral palsy to prevent contractures?
Yeah, I think that's a really important concern, particularly as with the decreased physical activity and just decreased access to therapies. I think that a survey that was done in Italy was really interesting because they found that when parents were able to maintain a similar level of activity or some sort of therapeutic content, I guess, for their children, that they didn't report any decline in their child's physical health status. But when parents and caregivers were not able to kind of maintain the same quantity of activity than they did. So I think that's where the challenge is because as we've seen, there's also a lot of other conflicts on parent and caregiver time. So, children may not be able to have the same level of stretching and other activity during the pandemic as not. However, I also think that parents feeling equipped to do some of these things at home plays a role too. So the amount that parents can feel supported by their therapists and other healthcare providers, sometimes it doesn't take much. In the Italian study, some of these parents didn't even have regular therapies available to their children. They just had, maybe a check-in phone call, and that helps them feel equipped to maintain the same level of therapeutic activity for their children. So I think, unfortunately, it does often come down to just our parents feeling equipped to help with, maybe not unfortunately, maybe fortunately, when parents feel equipped to help, I think they can really make a big difference.
Leaky, how's that for a response?
Yeah, Bernadette, do you have anything to add?
No, I don't. And I think Jenny just raised her hand as well, please.
Sorry, just another question. Do you have a hip surveillance program? Because I'm wondering if that, and in the countries that have a good hip surveillance program, whether they'll be able to track differences in the rate of change than perhaps have been there in the past, to look at big populations and say, yes, it has made a difference. And that might be one way of doing that. Because unfortunately is not old enough to show changes.
Right. Ellen, do you have a response, or would you like me to also respond?
Yeah, if you have a response to that.
Sure. And I'm going to lean on Dr. Linda Kroc as well, if you'd chat or just audio, in terms of the relation of the hip surveillance program and responding to Jenny's statement. And Leaky as well, if you have a hip surveillance program, I don't know. Let's see if yep, Dr. Kroc.
One of the challenges in the United States is that we don't have a national registry and we don't have national guidelines, unlike many other countries. So the institution I'm at Gillette Children's Specialty Healthcare, we do have a hip surveillance program. So I think it will be interesting to look at things going forward, but I'm not sure what conclusions we'll really be able to reach depending on at what point in time individuals are due for their hip images. So I'm not sure we're going to be able to correlate this with anything.
Mm-hmm. Mm-hmm. Jenny, I'm going to ask this back to you. What do you have in Wales, and how do you think that might relate?
Well, we have the CPIPS program, which came sort of from Sweden via Scotland. So there is a more regulated measures, and it's not then just looking at the hip angles, but quite a lot of range of motion movements, and it's now in place throughout most of Wales, but unfortunately it's not in a good electronic form yet that we can kind of centralize it all and measure, because it's that I thought, you know, it might be, because I think COVID's going to be with us for a while, and whether or not then, you know, it shows that the ranges of movement have changed at a different rate to they have in the past. But unfortunately I don't think we've been collecting our data in a central way long enough to do that. But you know, somewhere like Sweden may well do, or some of the other countries that have got those very set national programs.
Thank you. Any other comments from anyone?
And this is Linda Kroc again.
Please.
There are several institutions in the United States that are starting to collect data by way of something called the Cerebral Palsy Research Network. So we will be collecting information on lots of different clinical parameters. However, it is also not mature enough to be able to yield any specific information at this point in time.
Thank you for that. Shiri, is it someone else? Shiri, did you have a comment as well?
Hello, everyone, and thank you. It's very
Wonderful.
late here in Israel, late at night. So
it's very late at night in Israel. Welcome.
In Israel, there's some guidelines about the hip surveillance, but I don't think there's a national database that is collected. I don't know, maybe there is, but I don't know of one like that.
Sure.
But there's a strict protocol when to send a child, how to monitor the range of motion, and when to I'm a PT also, I'm a physical therapist, and there's a protocol where when we are sending a child to orthopedics and consult with them, and every 6 months, I think, there's a X-ray for the hip for GMFCS 4 and 5.
Okay. Okay.
1 and 2, it's first into the first 2 years of the life. They have to do it once, and if it's okay, then you can do it 1 year. But if it's not okay, it's every 6 months also.
Interesting. So in Israel, if you don't mind me asking you, what is the lockdown right now? Is there a lockdown for these families of children with disabilities?
We are in the second lockdown. The first lockdown, everything was closed, including everything besides the hospitals. Also the daycares, rehabilitation centers, special educations, also everything was closed. We saw all the children, they came back with how do you say it? Help me.
When they were able to be released from the home or still stay at home?
Nowadays, we are still in, there was a release and everything came back to some normal life.
Okay,
but now it's a second lockout.
okay,
But this lockout, the special education, which I work there, it's open, and we treated the children like we used to.
okay.
Rehabilitation centers, everything is open for the treatment.
So different than the first lockdown, the second lockdown, you have access to seeing these children.
Now they came normally with their family. They have special papers that they can go around and come to treatment.
And did all of the families return?
Yes.
Yes.
My family says, yes, they all returns. They really have your research was very similar to what our family said, that they felt the burden of treatment a child at home. They needed our help for the daily routine of the treatment. And I know from most of my colleagues that the patients are all back and that they want to come. Now in the second lockout, I work in two places. I work in special education and in clinic. So special education, everyone came. But in the clinic, I asked them who wants to come, who's not. And everyone, they felt like the children is going backwards with the tones and the control, and so they want to come back.
Very interesting. So you can be in United States and you can be in Israel, and there's very similar themes that I'm hearing. Linda or Ellen, any comment to what Shiri just shared with us?
I think the caregiver experience sounds very similar, and the caregiver concerns. I do think that perhaps in the US, well, the timeline of the lockdowns was a little bit different because we haven't really we've been incrementally, I think, easing restrictions. But I will say that a number of caregivers did express, that they actually preferred the telehealth therapies in some circumstances. So I do think it'd be interesting if we followed up with them to see if they're still going with telehealth therapies, the ones that really liked it, or if they have transitioned back to in-person services. And I don't know that because we haven't followed up with them, but I do think that for some caregivers, when telehealth was available, they actually really, really liked it.
Thank you. Linda, any additional comment?
Yes, I really think that those who appreciated telehealth the most were those who had difficulties accessing the physical, when indeed they had to take their kids to a certain location. I'm thinking mainly about those who lived in rural areas.
Okay.
Had to drive long distances. Or even though I think one person was concerned that with her children, she would have to bring other children. She didn't have someone to take care of the other children. So I got the impression that telehealth was very important to parents if indeed there was more of a concern about other children. But there was also a negative impact of telehealth if other children were home. Mm-hmm. So I think it was very mixed. But I found the most positive responses were from those who were equipped to do the work at home, parents who had the ability, had training, those who had very good internet access, because that's something we haven't mentioned. The technology that some parents would have as a concern. So I think it was just mixed. But the most positive, I think, came from those who had to drive very long distances or were concerned about family responsibilities taking the child in.
Great points. Great points. Any other comments?
I was wondering if I could just make a comment as a provider of telehealth services.
Please.
And this is Linda Kroc again. And it was really interesting to me that there were in many cases real advantages to seeing the people we serve in their homes. I found that some people who told me they walk all the time don't walk all the time. Or some people who told me they use their standard don't even have it in the house and set up. So it provided additional information that I can't get in an in-person clinical visit setting, but it was frustrating in that I couldn't put my hands on the individual and check their spasticity or check other things that I wanted to check. I got good at trying to coach people at active range of motion, but that doesn't tell you everything.
That doesn't tell you everything. So Dr. Kroc, if I can ask you a question back, do you think that people were hoping that their child could use a stander, or hoping that they were walking potentially more than they would, or that would be a goal for them?
Sometimes I think that there is just this human tendency to tell people what you think they want to hear. So I think that sometimes that's part of what we hear in a clinical setting. And it's not that they're intentionally misleading, it's just they want to please people. And so I think sometimes they make those statements just because they think that's what we really want to hear, as opposed to what the real experience is. I think too, for some people, their physical arrangements changed, particularly when there were multiple children also trying to school remotely, so that things became much different physically at home than they typically are.
Thank you for that reflection. We have just a few more minutes left, and I want to ask a question of the speakers. One question that just came up from Bella, who Bella says that she's not really fluent in English, but she just wrote a sentence better than I could. So I welcome that. So her question is, what do you think about digital poverty, which is really a concern in some countries that are still developing or have limited access? So I'll flip the order of this. Linda, what do you think of digital poverty that Bella's describing in this question? Great question.
Great question. I think it's definitely an issue. And in urban settings, it's an issue. Okay, when you think of poverty in the United States, you tend to think of ethnic populations and urban settings. But what we in Western New York have found is that it's the rural settings. It's the families who live in the exurbs. Because we have, in the state, we have even sued one of our internet providers who promised to put internet access out in the more rural communities and didn't do it. The problem we have here in the cities and urban environments sometimes is a lack of physical equipment. School districts have been able to give the kids enough physical equipment, but the problem is that internet access. And while it is a concern of urban areas, and it's a concern when we think of poverty, but we have to put all of this in a much larger perspective on infrastructure. We need to have the infrastructure and put internet capabilities throughout the country. And I think so, as I said, in Western New York, it's more of access in the rural communities than access in the urban areas.
Thank you. Thank you. Ellen, do you have a comment as well to that? We've just got one more minute left.
Yeah, I mean, I completely agree with what Linda's saying. I think from an international perspective, I think that's going to be one of the really important things that's going to come out of the IACD kind of whole survey collaboration. So we'll really be able to get an idea of how that does impact people around the world, because I think our survey is, of course, so limited to the particular region of the United States that we're studying. And I think that's going to be, yeah, a really impactful outcome.
Thank you. So I want to say thank you to the speakers. This was an excellent discussion. I am humbled by all of the questions and comments. What a great group of people assembled here today. Excellent work, Ellen and Linda, and thank you for sharing it with us. And for every participant on this, whether you're near or far, this fantastic session and series of sessions, apart but together, we are all together in this. And so by sharing our thoughts and perspective, we bring ourselves closer. Of course, we bring ourselves closer in our combined mission towards what we do with these wonderful people across the world. So we can't thank you enough as representatives of the IAACD and this task force, but also just to be together today is quite an honor and quite a gift. So thank you very much to the speakers. Thank you, everyone. And hope you're able to still attend. We have still a few more as the sun goes across the globe. So we look forward to you attending other sessions, and please feel free to reach out to us in the many ways that we have offered. Take care.
Thank you, everyone. Thank you. Bye-bye.
Thank you.